People have a lot of misconceptions regarding the development process of a generic drug. But when you look closely, it's much more than making a one-to-one copy. We utilize top-class science at a level most people wouldn't expect, using state-of-the-art equipment at our world-class facility in Prague. It feels great to make a difference to the number of people who can access high-quality, affordable medical treatment thanks to our work. People have a lot.
Bună ziua! Revenim cu ultima sesiune legată de vaccinare și vom începe cu prima prezentare a profesorului Ioan Solovic, pe care îmi dați voie să-l invit. Hello, Professor Solovic.
Hello, nice to hear you.
Okay, we are very honored that you are here. Sorry for a little delay in the program. We are very glad that you are here. And let me introduce you to my Romanian colleagues. So Dr. Ivan Solovic is a pneumology professor at the Health Faculty from University of Rozenberok, Slovakia. His interest, clinical and also research interests, are mainly in the tuberculosis domain. This is clearly reflected by numerous publications that he has in this particular field, and also by his official position in national and international professional organization. He is the head of the TB department from National Institute of TB, lung disease and thoracic surgery in Slovakia. He also is the president of National Society, Pneumological and Physiology Society, and also he's a long-term collaborator of various international organisms, WHO and ACDC. Currently is the head of WHO Collaborating Center for working with population that is vulnerable in various domains. So he has a lot of expertise in this domain. His talk today is about the adult pneumococcal vaccination. Please, Professor, we are very glad to hear your talk.
Dear ladies and gentlemen, it's a great pleasure for me, and thank you very much for your kind invitation to this very important meeting. Exactly, it's for the first time that I'm speaking for the Romanian. Sorry not to be face-to-face. I know in this COVID pandemic time, it's very, very problematic. Can you please start my presentation, or I have to share it? I have to share. So I have now to speak about the adult pneumococcal vaccination. After Professor Avcin from Slovenia, it's exactly very problematic to speak now to turn from COVID-19. And I know that in the program, it will be following the next presentation about COVID-19 vaccination. Exactly, I will now speak about the vaccination, which is exactly known for more than 40 years, exactly 44 years old vaccination, adult pneumococcal vaccination, which is on market. But still, I do not know how is the situation in Romania, but I have seen through the ECDC data that the situation is very simple to Slovakia, that adult pneumococcal vaccination is approximately about 2 to 3% of the population. And exactly in this case, we are speaking that most or all of adults in age over 65 need to be vaccinated against pneumococci. Exactly this pneumococci pneumonia can be the cause of deaths by these patients. And this is the greatest problem. We can see it also in this COVID time, and exactly in what was very useful for pneumococci vaccination exactly was the situation in March when Angela Merkel was vaccinated against pneumococci, exactly that gives the attention of the world population that we need to speak about also, that we know that now is the main thing for us is the COVID-19 vaccination. But still we have here the pneumococci infection, and we have still the cause of death need not to be only COVID-19, but it can be these old infections, diseases like tuberculosis or like pneumococcal pneumonia. So the pneumococcal diseases, exactly, they can be divided into invasive pneumococcal diseases and non-invasive pneumococcal disease. By the invasive pneumococcal disease, it's meningitis, bacteremia, and pneumonia with bacteremia. Beyond asymptomatic colonization, so this nasopharyngeal carriage, pneumococcal diseases states range in manifestation from relatively mild acute otitis media or sinusitis to life-threatening invasive diseases like complicated pneumonia, bacteremia, and meningitis. Pneumococcal bacteremia may develop secondary to pneumococcal pneumonia as a primary disease with no identifiable source of infections, and is the most common clinical manifestation of pneumococcal disease in children less than 2 years of age. Pneumococcal meningitis has emerged as the leading type of bacterial meningitis in children, with the decline of disease caused by Haemophilus influenza in this age cohort, and continues to be the most common type of bacterial meningitis among adults. And pneumococcal meningitis can result in long-term neurologic sequelae, including hearing loss, mental retardation, motor abnormalities, and seizure in 25 to 56% of survivors. Importance of non-bacteremic pneumococcal pneumonia, because yes, the bacteremic pneumococcal pneumonia is the great problem, and this is as pneumologists, we are taking care for these patients. But non-bacteremic pneumococcal pneumonia, this community-acquired pneumonia, is a significant cause of morbidity and mortality among adults worldwide. We know that this was and this is still the greatest problem, of which a significant proportion is believed to be caused by Streptococcus pneumoniae, so-called Ostopneumococcus. In turn, the largest burden on community-acquired pneumonias, approximately 75%, is attributed to non-bacteremic pneumococcal pneumonia. In developing countries, non-bacteremic pneumococcal pneumonia causes the majority of deaths due to pneumococcal diseases in children. Therefore, non-bacteremic pneumococcal pneumonia is a major public health concern. As we are speaking about from the history, since 1990, there has been a 30% reduction in the incidence of pneumococcal disease and 50% reduction in mortality in pneumococcal diseases in children under age 5. In 2000, Streptococcus pneumoniae caused 826,000 deaths in children in the age from 1 to 5 years. In 2015, so 15 years later, pneumococcus was responsible for 317,000 pneumococcus deaths in the same age group. So this PCVs has prevented 250,000 cumulative pneumococcal-related deaths from 2000 to 2015. Invasive pneumococcal diseases, the incidence, these are the most serious and very problematic cases of patients which need to be treated, is the bacteremia or bacteremic pneumonia, which is 26%. So 7% meningitis and 1% other clinical presentation. Estimates of global mortality associated with pneumococcal pneumonia, global burden of the disease. This is the study from 2016. Global mortality due to pneumococcal pneumonia remains a burden, partly due to low vaccination coverage in high burden locations. However, this has been some reduction in deaths over the time attributed to PCV introduction in children in many countries. We can see that in all ages, there is less than 30% change. Three populations are at the highest risk for pneumococcal diseases. These are the people at the extremes of life, either less than 2 years or the age over 65. As a pneumologist, yes, and work for adult, I'm working mostly with the patients over the 65 years of age, and these are the very serious problem for all of us, and not only for pneumologists, but for all, because also you as a rheumatologist, I think that your majority of patients, complicated patients, are over the age of 65. Then are the people with underlying chronic diseases. This is our similarity, this is our accumulation of patients, and immunocompromised people. The risk for invasive pneumococcal diseases increase with age and underlying conditions, like the studies from 2006 to 2010 in the United States, and we can see the highest number are the patients with congenital immunodeficiency and functional or anatomic asplenia. But then on the second, the second high group are the chronic lung diseases, chronic liver diseases, and then patients with immunosuppressive conditions or immunosuppressive drugs. And these are our patients which are cumulative for rheumatologists and pneumologists. We need to think about this, that these patients are the very risk for invasive pneumococcal diseases, and that we can a little bit prevent this disease by the vaccination. Seasonality of invasive pneumococcal diseases in Europe, we can see the seasonality is like the season of invasive pneumococcal diseases. As I can say, start in October, the highest is in the winter period, and we are finishing in April, May, and then the summer months, the relatively situation is better. And since we are now speaking in this COVID pandemic time, or in this COVID period, exactly that, yes, vaccination, the vaccines, which is now for 6 months or 6 months used and so, but now the COVID-19 versus vice versa pneumococci. Pneumococci vaccination known and start in 1977. So that 44 years till now, and still it is not used as it needs to be. And this is the problem of all of us, that we know that we have this possibility to vaccinate. The PPSV23, Pneumomax 23, exactly, it's from available at the market from world market from 1983. And then the pneumococci conjugate vaccine 13 expanded in indications in adults over 50 years in European Union from 2011, in children from 6 to 17 years from 2013, and in adults from the 18 to 49 exactly for 2016. Still, it is now 5 years ago, and the numbers are relatively the same, a little bit higher, but still it is not so wide use as it needs to be. And exactly this is the greatest problem, that we are speaking about the pneumonia-related deaths, and it is all the age group. We all think, yes, it was the older patient with comorbidities and the pneumonia as the major as the cause of death. But if this death was preventable or not, we are not all times doing this rethink that maybe in case the patient were vaccinated half year ago, that the death will not become on the table. Impact on PCV infant immunizations programs on incidence of IPD in children. Retrospective analysis was explored in impact of PCV infant immunization programs in several countries. In the pre-PCV era, the overall reported invasive pneumococcal diseases incidence in children with less 5 years old was highly variable, and ranging from 17 to 94 cases per 100,000 child years, with the highest incidence in North America and the lowest incidence in European countries. We are happy that we are relatively the lowest incidence, but still it is after the introduction of PCV, regardless of the size of the data set, the pre-PCV incidence schedule, duration of PCV programs and PCV use, the incidence of invasive pneumococcal diseases was lower in all countries studied. As you can see, it were the countries Australia, Canada, Denmark, Finland, France, Israel, New Zealand, Netherlands, UK, and US. Retrospective analysis by on the impact of PCV infant immunization on incidence of IPD in adults over 65. We know that by the immunization of our grandchildren, we take care also for our grandparents. So this is hand in hand. And the retrospective analysis shows that also that after 5 to 15 years of PCV use, non-vaccine serotypes have become the major contributors to IPD burden in older adults, with 43 to 79% of IPD being caused by non-vaccine serotype. So this is the greatest problem, and also that we can see that the non-PCV serotypes in adults increased after PCV introduction in children. So that we introduced the pneumococcal conjugate vaccines, and then the serotypes which are not included in this vaccine are now going up, and the vaccine serotypes are going slowly down. So this is, but on the other hand, still we can see that the situation is being better in many countries, and it's very useful that we have to think about how to protect our grandparents. We need to vaccine the grandchildren, and hand in hand we can work together and to fight against pneumococcal invasive diseases. Serotypes in PCV7 and PCV13 cause the majority of disease prior to PCVs. Therefore, care must be taken to ensure these serotypes do not return. Incidence of residual diseases is significantly lower than in adults, and a large proportion seen in the first year of life. Residual diseases among adults is larger than among children and is comprised primarily of non-PCV serotypes, except for serotype 3. As we see, serotype 3 still contributes to significant burden of diseases in key countries. Serotype 3 remains important contributor to invasive pneumococcal diseases, despite the broad use of PCV13. So that they are ranking among residual disease. Serotype in the first place is serotype 3 in the US, then Germany, then also France, Spain, Japan. Some serotypes have a greater potential for progression to invasive pneumococcal diseases. We know that the specific impact of capsular pneumococcal serotypes is as follows: that serotypes 1, 4, 5, 7F, 8, 12F, 14, 18C, and 19A have the greatest overall invasive disease potential. This is what we know, and this is also in the cooperation if you have in your country, and depends on countries, national reference laboratories, if they can, and exactly not only because all of our countries we have the possibilities to do all these tests. We can give the typization of the serotypes, but we need from the general practitioner. And this is the greatest problem, that in the fight against pneumococci, we need to have greater cooperation between the general practitioner and the lung disease specialist and microbiologist or the public health officers or laboratories where the serotype typization is done. And this is the greatest problem in Slovakia, that we still have the problem to put the biological material and to do the serotypization. Because association between pneumococcal serotypes and diseases in adults, then we have that is increased associated serotypes which increase disease severity is, for example, the serotype 9N, 11A, 22F, and 33F. High increased prevalence among adults, back again the same serotypes 8, 9, and 11A, 12F, 22F, 33F. So the same serotypes which are. We know that we have more than 90 serotypes, but not all of them are so invasive, so they can be a cause of the invasive pneumococcal diseases. From my point of view as a pneumologist, bacteria to be the cause of invasive pneumonia, bacteremic pneumonia. Distribution of confirmed serotypes caused of invasive pneumococcal diseases. The most common Streptococcus pneumoniae serotypes are the serotype 8, 3, 22F, and 19A, 12F, 9N. You can see on the slide. So challenges, some important serotypes are not covered by existing conjugate vaccine. So the available vaccines for infants, such as the pneumococcal conjugate vaccine PCV13, target only a subset of the more than 90 circulating pneumococcal serotypes. However, only a proportion of these cause serious diseases in humans. So the global pneumococcal sequel cluster, expressing invasive serotype 8 in South Africa and serotype 33F in US and Israel, was the most common lineage causing non-vaccine serotyped invasive pneumococcal diseases in the period following the introduction of PCV13. In Europe, it is the serotype 8, serotype 3, and serotype 22F are the most common contributing serotypes of invasive pneumococcal diseases in adults. And then to speak about the immune response, we know that we have at the market now pneumococcal polysaccharide vaccine and pneumococcal conjugate vaccines. What are the differences? Both of them are very useful. That both of them need to be we need to know that we have this possibility. Then the pneumococcal polysaccharide vaccine is T-cell independent immune response. In pneumococcal conjugate vaccine is T-cell dependent immune response. Then the difference, pneumococcal polysaccharide vaccine has low absent immune response in infant and the young children less than 2 years of age, and in pneumococcal conjugate vaccine, effective immune response even in less than 2 years of age. But no in pneumococcal polysaccharide vaccine, no introduction of the typical immune memory response following revaccination. But in pneumococcal conjugate vaccine, immune memory induced and in infants and young children, leading to an amplified and accelerated antibody response following additional doses. So that what types of studies have been conducted to evaluate the efficacy and effectiveness of vaccines? This efficacy control were the controlled clinical trials, and effectiveness was the real-world evidence. So evaluate clinical response under the ordinary conditions of a public health setting. So from historical side, summary of data referenced in the prescribing information for PPSV23. So these are the historical data. So evaluation was, you can see these are data from 1993 or Smith data from 1977, and exactly we have we can see the efficacy and effectiveness of this vaccine of this vaccine. PPV23 should be recommended for routine vaccination of the elderly. Sequential vaccination with conjugate vaccine PCV13 followed by the PPV23 may be justified in countries where a large proportion of pneumococcal diseases in the elderly is caused by the PCV13 serotypes, so by the serotypes which are in the pneumococcal conjugate vaccine 30. So this is what PPV23 has demonstrated efficacy and effectiveness against invasive pneumococcal diseases, but also against pneumonia. So ACIP recommendation. ACIP, this is the advisory committee on immunization practices, and then there is a little bit difference between 2013 recommendation when short-term recommendation for sequential use of PCV13 followed by Pneumovax 24 for adults over 65. The new recommendation in 2019, all adults over 65 years or all 65 years or older should receive a dose of Pneumovax 23. ACIP recommends PCV13 based on shared clinical decision making. So that what are the updated recommendations? Exactly, routine administration of a single dose of polysaccharide vaccine, so PPV23. All immunocompetent patients, polysaccharide pneumococcal vaccine for adults who only received a dose of PCV13 or after age 65 based on prior ACIP recommendations, routinely administer PPV23 at least 1 year later. And in the case of immunocompetent adults, no underlying medical conditions or with certain chronic conditions, and this is the great group of our patients. So PCV13 at age 65 or more, if warranted based on shared clinical decision making, and then PPV23 after 5 or more years after any PPV23 at age 65 years. In case that we have immunocompromised adults, and these are the chronic renal failure, congenital or acquired immunodeficiencies, or HIV positive patients, malignancy, or immunosuppression therapy, so that these are the greatest group of your rheumatologist patients, so that if PCV13, if not previously vaccinated, and then after minimum 8 or more weeks later, one polysaccharide vaccine, PPV23. So by the end, take-home message from this, the WHO guidance for immunization services during this COVID-19 pandemic, that countries should take what steps they can to sustain immunizations program and prevent unnecessary loss of life. Outbreak of vaccine-preventable diseases could be catastrophic for communities and health systems already battling the impact of COVID-19 and substantively increase sickness and fatalities. All immunization services must consider the importance of both ensuring people are protected against preventable diseases, as well as the safety of communities and health workers. So these are the summary of the WHO recommendation, and exactly it's necessary that in this COVID pandemic period, we need to think and look at the patients. I know that as a pneumologist, yes, in our country, in Slovakia, we are now working 90 or more than 90% of our patients are now COVID patients. And but on the other hand, all other diseases are still here. Still is the greatest problem that we need not to look at the patient not only as a COVID or non-COVID. We need to look about this non-COVID patient, that they are here. We need to take care for them. And this is the greatest problem all overall, because it was the same data where this week, it was the World TB Day, and exactly in the whole Europe, we see a decrease of the fall down of incidence of tuberculosis more than 20%. And if it's the real data, or if it will be only falling down up in next years, we all think that this decrease of tuberculosis, the decrease of the falling down the numbers will be coming up in some next years, according that there at the moment there were no the patients are aware to go to the doctor, and exactly to visit the pneumologist is the greatest problem, because they think that they can be infected by COVID infection in the waiting rooms or during the meeting, and so these are the greatest problem at the moment, and so that we need to think that protect against all preventable diseases. And so invasive pneumococcal pneumonia, non-bacteremic pneumococcal pneumonia can be prevented, but still I know the data about Slovakia, only 3% of the chronic patients who need to be vaccinated are vaccinated. Thank you very much.
Thank you also, Professor, for your excellent talk. I would like to ask if there are any questions from the audience.
Yes, I want to.
Please, Professor.
Hello, thank you very much for your very nice presentation. As we know, there are some vaccines that should could stimulate the immunity to reduce the risk of COVID-19. And when we discuss about BCG or about anti-influenza vaccine, we know that for these vaccines, there are trials to demonstrate the reduced risk of COVID-19 for patients who took this vaccine before pandemic. The question is, there are some studies that pneumococcal vaccination could also confer low an immunity or an increased resistance to SARS-CoV-2 infection?
Yeah, I said I know about the studies about the BCG. Yes, we know that there is the Australian study and the Netherlands study that yes they have, because in Netherlands they can do this study exactly. The population was not BCG vaccinated, so that they were touching more than 2,000 health workers, which were included in the two cohorts, BCG vaccinated and non-BCG vaccinated, and now they will take care for them and look after the patients for 1 year and look if that has impact of this BCG vaccination. This was in the first wave of the first wave of outbreak of COVID-19. Also, it's the Australian and New Zealand, where exactly the same problem and the same. But about pneumococci vaccination, I do not know and I have not seen at the moment that there were studies. We know that for the pneumococci, there are exactly pharma companies which are now producing also the COVID-19 vaccine, so that I have not seen studies that there is something that this against what was exactly proposed, and it was in the first wave it was also by Angela Merkel that when it was not anti-COVID-19 vaccine, then vaccination against flu and against pneumococci has to protect the person, but not against the COVID-19, but against the complication, which is serious complications, is exactly the bacteremic pneumonia.
Thank you.
Thank you. Also, I would like to add a small comment regarding this issue. I would have asked the same question. Thank you, Professor Lupce, for this question. As I'm aware, I have seen a very small study from Cleveland Registry that showed that patients that were vaccinated with pneumococcal vaccination were not so frequently infected with COVID-19. But I'm not aware about any other studies. This is the only study that I have seen that probably patients that are vaccinated prior this infection are a little bit more protected. I'm not exactly aware about the mechanisms, but probably the same diffuse activation of the immune system, it will work. I'm not sure of it.
Yes, I think also that it will be the activation of the immune system, as I have on some slide, it's shown that there is how the vaccines are exactly stimulated the immune system, so that we hope that exactly we know that the COVID-19 is, yes, the bacteremic super infections, or by this virus infection, the bacteremic super infection is very often and coming. But on other hand, we have in Slovakia more than 90% of our populations in the houses of elderly. They were compulsory vaccinated against, and still we have some houses. It depends, but still the numbers in these houses for elderly are not so high as the population who was not vaccinated. So that it's the general public houses of elderly, there is compulsory, not so many deaths as in the private houses of elderly, where often also COVID-19 was the cause of death by these clients.
I only want to make a comment. I don't know really which is the number, but we have to admit that also in Romania and in our population, in the immunodepressed patients, the rate of vaccination of anti-pneumococcal vaccination is very low. I think it's below 2. I think it's very low, and we have to work on it, because also influenza vaccination and adult, and we will have a talk about this, is mandatory in our patients, and it's not used at all. Thank you.
Thank you very much.
Thank you. If there are no other questions, we will proceed with the next speaker.